Welcome back to this session about clinical pathways. I'm happy to pass the word to our new president in the IS, Dr. Ian Jackson from UK, who is going to step in instead of Doc McWhinney, who is unfortunately not able to be here today. So I'll pass the word to Ian.
Thank you very much. I'm really anxious about this because some people in the audience might know Mr. Doug McWhinney, and he does have a habit of putting some funny pictures into his slides. So these are his slides, they're not mine, and what I would like you to do is to try and help me interpret what he actually meant to say today, because I've never heard him give this talk. We're talking about pathways, and I think his mission or his statement here is that actually getting the start of the pathway right is critical. Choose the wrong starting point, and you will end up in serious trouble when you get to the end of the pathway. This is a schema of a day surgery pathway that we consider that we follow in the UK. And I'm sorry, I don't have a laser to point through it, but it goes from the left-hand side, from the referral from our primary care colleagues, our general practitioners, through to the right-hand side, where we have discharge and immediate post-operative support. So it's a complex pathway, but that is what we'll be looking at. And what Doug likes to think about is about the rate-limiting steps within that pathway, or certain key areas. And the key areas that he was planning to discuss today were the selection criteria, looking at assessment, patient admission, theatre efficiency, and discharge process. So let's have a look through those. I'm going to skip through some of these because they'll be covered by the next speaker, so I don't want to encroach too much on her talk. But the selection criteria that we use really go through three areas. One is obviously the medical fitness of the patient, but we also have to think about, is the surgery appropriate? What is the surgical process? And also about the home circumstances and the social support that a patient has. Interestingly, we did a study a few years ago where we looked at the length of time a carer stayed with a patient following day surgery, because we recommend to all our patients that they have a carer at home for 24 hours following discharge. And what you find, and I'm sure if you've followed up your patients as well, is most patients were by themselves by the next day because the carer had gone back to work. It tended to be less so for children, but for adults, husbands and wives, they tended to say, cheerio, I'm off to work, and leave the patient at home. So it's worth thinking about the social circumstances. The medical criteria that we consider are always changing. We look at everything from the age of the patient to the degree of obesity, whether they've got comorbidities such as diabetes, whether they're smokers, but we are pushing the boundaries everywhere across the world. And of course, one of the messages is start safely and gradually build as you get more experience. But build we have to do, because one of the things that we are seeing across the world is a worldwide obesity epidemic. And if we look at a definition of obesity being a BMI of greater than 30, we can see that in the States, they're talking about over 74%, no, it's 72% there, of patients reaching a definition of obesity. But it's happening to all of us, Australia, UK, it's happening across the Western world, and not just the Western world. I apologize for the picture. I told you, Mr. McWhinney likes putting in funny pictures. I apologize for that. But what he is trying to advocate here is that actually we shouldn't have too rigid selection criteria. So even when we have patients who are obese, if we choose the appropriate procedures and we have the appropriately skilled staff and equipment, then we can still do them as a day case. Social criteria. The ability, in the UK, traditionally, we work on patients being within 1 hour from home, from discharge, 1 hour's travel time. But actually, even that we stretch. York, where I work, is a student, has got York University, and so we have lots of students from all across the UK. And following certain types of procedure, I'm quite happy to send them home to their parents, even if they're 2 or 3 hours away. So someone who is fit and well, who has a knee arthroscopy, I see no reason why they can't travel home as long as they have someone to travel with. But we must always consider the availability of phones and a responsible colleague to look after them. Thank goodness there was no funny pictures on this one. Surgical criteria. One of the things that we're seeing, and it's happening everywhere, and you've been hearing about it this morning, is the increasing range of procedures that are suitable for ambulatory surgery. Minimally invasive techniques are changing this, and not just for abdominal, but also thoracic procedures done endoscopically and allowing patients to go home. We, a few years ago, had a success story where one of the surgeons from Stoke-on-Trent completed the first day case laparoscopic nephrectomy. He's now done a series of these from his unit, and we're increasingly seeing patients having thyroid surgery, parathyroid surgery. And the interesting thing for me about that is, I've been in this game a long time, and in the early 90s, when I suggested in our Journal of One-Day Surgery that we could actually probably do thyroid surgery as a day case, and reasonable numbers of them, I got hate mail because people thought this was just crazy and that the bleeding risk was too great, and it was just, you couldn't consider doing it. But how times change. And he's right in what he's saying. The degree of surgical trauma is more important than the duration of the procedure. And I think that's largely because of the success we've had in anesthesia, how we've moved things forward in anesthetics. So actually, in the old days, we used to talk about a 1 hour limitation time for any operation to be done as a day case. And that went out the window several years ago. But it is important that you have, at the end of the process, a patient who has pain that can be controlled by oral analgesia, has no requirement for IV fluids, so they can actually take fluids, and has a low risk of post-op complications. And so what Doug is suggesting here is that we gradually evolve, and that's what we do in day surgery. We start off with criteria, and then we gradually relax those as we gain confidence in how we're working with the patients. So it's actually, we look about what the procedure means for that patient rather than what the patient means. I don't intend to cover pre-assessment because Anna is going to cover this, and I just spoke to her before I came up here. But really, Doug was saying about that you have to look at pre-assessment and basically change the philosophy so that we're moving much more to what we heard this morning. Actually, do we default patients to a day surgery pathway, and they only get routed out of there if they're not fit for day surgery? And as I say, I won't go through all the options. If we look at, this is quite an important one, if we look at the typical surgical pathway, a referral from GP through to decision to operate, that's a sort of common pathway in the UK. And so you have an outpatient view, there may be diagnostics, then another outpatient review with a decision to operate. And then there's a decision often by the surgeon as to whether the patient is a day case or an inpatient. I think we're moving on from that, and Anna will deal with that. But the main message that we have is actually trying to get that pre-op assessment process as early as possible. Because as has been discussed in other sessions, finding out the week before that your patient has got some condition that precludes them, or they need to stop some medication for 10 days before their operation, then you have no chance of dealing with it at that stage. So trying to identify issues early will increase efficiency. There was a very interesting article done by one of our colleagues on the British Association of Day Surgery, and that they had access to 3 separate day surgery units. because they'd had separate hospitals. And they looked at their unplanned admission rate from the 3 units. And I think the message here is that dedicated facilities, whether a satellite unit, standalone, or a dedicated day unit within a hospital, has a much better chance of managing the patient pathway and getting the patient home. Inpatient wards are not suitable for day cases, and as you can see here, the admissions that stay in overnight rate is much higher if you try and manage day surgery patients through those facilities. If you're looking to shorten length of stay as well as day surgery, then having facilities for admission, an admissions unit, so that patients can come in on the day of surgery can be really efficient if it's located nice and close to theatre, and based on the use of chairs, not trolleys, and patients walking to theatre, and only with the patient being admitted after theatre. Doug's got great interest as a surgeon in theatre costs. And obviously, the variability in this, with these stats at the bottom of the slide, ranging from £900 an hour to £1,620 an hour, which is the cost for his hospital. I know within my own unit that a 4-hour session costs us something like £2,200, so about €2,500, somewhere around that mark. And that doesn't include the cost of the surgeon, but it does include the cost of the anaesthetist and all the associated staff. So his message there is about trying to use the theatre facility efficiently. And when you have a facility that doesn't have dedicated day surgery lists and dedicated day surgery facilities, it is important to try and get the day cases done early in the day and leave the more major cases till later in the day. Mind you, that goes against the grain for most surgeons, because most surgeons would like to do the major case first, so they are in the hospital for a longer period while that patient is in that first stages of recovery. I'm not going to talk too much about this, because this is about gap time, and Doug, being a surgeon, is fascinated by gap times, which includes the anaesthetic time, and me being an anaesthetist, I'm slightly more interested in what the surgical time is rather than the gap time. But one of the messages is about trying to improve the efficiency of how quickly we turn patients round. And that's one of the things I feel, certainly within my own day surgery unit, that we can do really well. Because if you're self-contained and have a ward nearby, then you reduce the delays in patients coming round. And so you have much smaller gap times between cases. And that in turn increases the amount of time that the surgeon has with the patient on the table ready to be done. And that's just some work that Doug did looking at operating theatre utilisation, which is rather like, I think, Paulo's presentation for those who were there yesterday. So looking at the relative amount of time that was operating and how much was available out of the whole theatre time. Now I feel I'm on to a bit more on stronger area. Bad's produced a nice booklet on nurse-led discharge and about the discharge process. And the discharge criteria are things that we should always keep a look at, because there are probably things within there that we can challenge for some procedures. But I think it is really important that your patient understands all the work that we've done in the UK, and certainly in my own unit, is that it's vitally important that you ensure the patient understands about the pain relief medication that you're giving them to take home. Because it's fascinating the number of people who report severe or moderate to severe pain who then say they didn't take the medication. So actually ensuring that they know about the medication and understand that they need to take it regularly is important. I hesitate to press the button, but here it goes. Driving after surgery. The insurance companies have a major effect on this, and we advise our patients strongly following procedures that they have to be very careful and ensure that their insurance company is happy for them to start driving again. So we try not to give them categorical at times, but the bottom line is they have to be able to perform an emergency stop without discomfort stopping them. So physical restriction due to the surgery is one of the fundamental things. And obviously that can be also problems with shoulder surgery and other types of surgery, forearm surgery. so actually controlling the car. Passing urine. That used to be a criteria for all patients, but it's one that we've removed. For large numbers of patients, we accept that if they're at low risk of urinary retention, young patients, it's not essential that they pass urine before being allowed to be discharged. And of course, I hesitated to press again with Doug and his pictures. So I think what Doug tried to do was take us through a mystery tour for me of the day and short stay surgery pathway. I apologize for some of his pictures, but I do wish him well, and I'm glad that I spoke to him the other day. He's feeling much better, and he'll be back with us soon. Thank you very much indeed.
Thank you very much, Ian. I think you did very well, and I think it was